Thank you very much, Charlie. And thank you, Diane, Mathias, for wonderful talks. We have some time for discussion. So first of all, if there are folks in the audience who'd like to submit questions, we'd be delighted to hear them and try to relate to them. We have about 15, 20 minutes for discussion, so feel free to submit your questions. Maybe to start things off, we were talking about some specific reduced drug regimens. We have quite a lot of approved antivirals. Are there other reduced drug regimens that perhaps we should consider that we haven't yet tried? Diane, any thoughts on that?
Yes, good morning to all. Thank you, Jonathan, for this question. Yes, we have other. I focused on mainly on new integrase inhibitor and nuke, but we have also we know that PI plus 3TC is also an option. There was a paper presented at CROI in 2016 from the Moby Deep study. It's an INRS, a French INRS trial, showing that PI plus 3TC give good results in maintenance, even if the 184V mutation was present at baseline, and the result was better than PI alone. So even with the 184V mutation, PI, it was lopinavir or darunavir plus 3TC, the response was better with the dual therapy than monotherapy of PI, with good results. So this also can be an option. We would like to have Bichat-Claude alone because it's only available in France. I think in the rest of the world also, it's only available with TAF plus FTC. So perhaps if we have Bichat-Claude alone, we should have tried this drug in dual therapy. The new use is always a 3TC or FTC. We don't have TAF alone also in France, so it's difficult to have data without the drug alone. I don't know if I respond to your question.
Yes, no, absolutely. I think it's good for to keep in mind that it's not one specific regimen. I think the characteristics of protease inhibitors are very similar to what we were speaking about a high barrier to resistance, and I think it's
we know also that some dual therapy did not work at all, such as I have my the number, such as raltegravir plus Araviroc or other PIs such as atazanavir plus 3TC. I don't remember. I
think, as you said, some of those were disappointing. That raltegravir, perhaps with its short half-life and low barrier to resistance, was not as good a partner. Another question I think that's becoming relevant, because many of our patients are undetectable when we're switching them. We're looking for technologies which will give us confidence that we're not missing resistance, and more folks are doing proviral DNA. I think many of us resistance folks have sort of gotten used to saying that if you see a mutation, it's there forever, and perhaps there we're really, with lack of data. The question I want to ask both Mathias and you, and actually happy to hear Charlie's input as well. When we see an archive mutation, in other words, when we do proviral testing and we see a single mutation, how confident are we that indeed this is a mutation that can cause failure? And would that change in a patient who's been undetectable for many, many years versus a patient who's detectable for a short amount of time? I don't know, Mathias, you want to take a first crack and we can hear everyone's thoughts on that?
Can I?
Sure, of course, Diane.
I think we have to distinguish between the delay of viral suppression, that more the delay is higher, more we can be confident, and what is the therapy you want. It's a dual or tri therapy. If it's a tri therapy, we are now confident with the Bichat-Claude studies, the 1490, I always mix up the number, 1499 and showing that 184V mutation was present in archive DNA. At baseline, it has no impact on failure, as well as other integrase inhibitor mutation as a 97A or 184Q, 184H, if I remember. So in tree therapy, we know that we have data now to suggest that archive mutations are not do not impact failure. For dual, if you imagine a dual therapy, this I think we need to have more data. I will not feel very confident giving a dual therapy if I see archive mutation.
Tell us a little bit about the whole concept of an archive mutation, the reservoir. I mean, for us clinicians, what are some of the take-home message we consider when we do those tests?
Yeah, hi, it's Mathias here. So I believe these are really good questions, and the recent development of technologies is putting us into a much better position to address that, I believe. I mean, an important distinction that we are making when we are looking at the reservoir is that there's really that large component of DNA sequences that is really defective, right? It's in the majority of people, it's something in the range of 90 to 95% of DNA that has some type of a defect that precludes replication. And if we find drug resistance in these types of defective proviruses, it really does have no implications for management. There's no expectation that that influences an ability of someone to respond to a drug or not. So that's why I believe there is a possibility now to distinguish intact from defective proviruses. And once we find drug resistance mutations in the intact proviruses, that's certainly, I believe, a more significant concern. And I'm not sure in the future, in certain cases, it might actually be possible to introduce that system into the clinic and do sort of deep profiling of the reservoir using some of the new next generation sequencing technologies that can probably do this in a relatively sort of a practical way and give us the information that we need, as opposed to sort of rely on guessing when we get the sequencing results from today's technologies, where we are not always certain, is that really clinically relevant or is it not?
It's a great point. I think, we extrapolate a lot with resistance testing, probably too much. And on the one hand, we want to be cautious, but we don't want to deny patients, I think in Tango, they did some exploratory work and it didn't seem to really pan out. I think, Mathias, the issue that, if one day you could give us a tool where we could really, define, are these replicated viruses or not, I think that's something that would make it much more relevant. Charlie, in your clinic, do you use proviral DNA testing? Is that something which is commonly done in suppressed patients?
No, Jonathan, is the simple answer. Mm-hmm. And part of the reason for that is, number one, the tests are expensive, and number two, it's hard to know how to interpret the results. And it's not just, are you able to detect proviral DNA that has resistance mutations, but what drug regimen were you intending to put the patient on anyway, and would it make a difference even if you thought the patient would be resistant to one drug out of a 3-drug regimen? So I think it's complex to fit into the overall picture of management. Yes. And right now, I don't believe it. I don't believe we have enough data to know that it's actually going to benefit outcomes. So Jonathan, also there is a question in the chat, if you want to go to that, which I think is an interesting question.
Yeah, so maybe I'll have Diane field that as really a world's expert on HIV too. I don't know if
yes, it's HIV too is coming back. Yes, thank you for your question, and for adorable. Which is, the question is, with the U equal U promotion, is it possible for HIV-1 infected person with a viral load of undetected, can he be infected by HIV-2 strain? I will say yes, he can, if he takes, take risk with another HIV-2 infected person. But you have to know that viral load in HIV-2 patient is lower than in HIV-1, and the risk of transmission is also lower for that reason. But the treatment used for HIV-2 drugs are not always susceptible as for HIV-1, so it depends on what the treatment is in this person who had viral load undetectable. If you receive non-nuc, these drugs are naturally resistant for HIV-2, so HIV-2 can replicate. But
so on that topic, I remember in the olden days, I guess the technologies we use for diagnosing the viruses have sort of evolved. I remember in the olden days, indeed, when you would see a patient sometimes with a CD4 count would continue to go down despite what we thought was undetectable. Our assays weren't able to detect actually HIV-2. Our standard assays today, will they give you a result of HIV-2 in addition to HIV-1?
No, they give only HIV-1. You need to perform a special molecular test for HIV-2. It's not detected. Some tests said they detected, but when you do quality control testing, the results are very are not so good. So you need a special test.
Good. So thank you for the good question. So that's definitely something to keep in mind. Charlie, one other question I wanted to ask you is, we're getting a little short on time. You know, adherence characteristic was something where we really felt the patient had to have very close to perfect drug-taking behavior in the bad old days. And obviously today, we continue to promote very good adherence, but we know that you don't have to have perfect adherence. What are some of the real-life considerations when we're thinking of a 2-drug regimen, a 3-drug regimen? Do you think that factors in patients who have not as good drug-taking behavior? Are they less appropriate to take 2 than a 3-drug regimen? Is that relevant for? What are your thoughts on that?
Jonathan, I really think it depends upon the drugs in the 2-drug regimen. We know that different classes of antiretrovirals have different barriers to resistance. We're very comfortable using boosted HIV protease inhibitors in individuals with a history of poor adherence, because usually when those individuals fail therapy, they're failing without resistance, perhaps because of resistance to other drugs in the regimen. But integrase inhibitors also have a very high barrier to resistance. And we know, for example, in clinical trials of dolutegravir, that the development of dolutegravir resistance, particularly in treatment-naive patients for whom dolutegravir is part of their initial regimen, resistance to dolutegravir is exceedingly rare, despite that drug being used by tens of thousands, if not now hundreds of thousands of patients. And so I think you can't make a blanket statement any longer about how many doses you need to take in order to not fail therapy. We know that people who take integrase inhibitor-based regimens are missing occasional doses, and particularly for dolutegravir and bictegravir, but also even for raltegravir, development of resistance to those agents is exceedingly rare. And that suggests to me that they are quite forgiving. I know that, you know, people have done studies where they have intentionally stopped the weekend doses of a regimen and shown that there was no significant increased risk of drug failure. And so you need to keep in mind that it's not just missing drugs and having your concentrations fall. It's how many days does it take for the virus to start replicating again to the point where you can select for drug resistance mutations. And so it's a rather complicated dynamic. And the longer the half-life of the drugs and the higher their barrier to resistance, the less likely you are to have consequences of missing 1 or 2 days worth of drug. So I think we should all be very reassured by that. I think the injectable regimens, as long as people show up for their injections, are going to be even better in terms of forgiveness. And so, you know, hopefully 10 years from now, we won't be talking about this at meetings like this one. But it's clear to me that things really are getting better and better.
Wonderful. Thank you, Charlie. And I think we're getting close to the end of our roundtable. So let me start by thanking our three speakers again for the wonderful talks and the lively discussion. Thank you very much. And I think we'll be closing the session if we have a few slides. So we're going to be taking a break. If we can switch to our slides. So we will be taking a 15-minute coffee break. And at the conclusion of our coffee break, we will have our next session. And we will have, again, three fantastic speakers and discussion afterwards. We still have a nice program ahead of us, so people can take a little break, get themselves something to drink, and we'll see you again in 15 minutes. Thank you very much.